What I'm going to speak to you about is understanding the experiences of and providing resources to support people with disability and family members from Syrian and Iraqi refugee backgrounds. And I'm going to draw on that research that we've been working on over the past 6 years to talk about that. So to start with, I would just like to also acknowledge and pay my respects to the elders, past and present, of the Wurundjeri people of the Kulin Nation in Naarm or Melbourne, from whose unceded lands I am presenting today. So some of these facts will be familiar to many of you, but I'm going to run through them because they really set the context for the research that we've been doing. So in the 2 years prior to COVID, 15 million Syrian and Iraqi people had fled their homes due to the war. And in 2015, in response to the scale of the Syrian refugee crisis, the Australian government accepted an additional 12,000 Syrian and Iraqi refugees, in addition to the existing 13,750 humanitarian intake from all countries. Priority within this additional intake was given to people considered to be most vulnerable. And this was defined as those with disability, mental health concerns, and those from minority communities, for example, Christians and Mandaeans. In earlier decades, the guidelines for reviewing humanitarian visa applications meant that many refugees with disabilities and their families were excluded from entry to Australia. However, in July 2012, the Commonwealth Government streamlined the health waiver for all humanitarian visa applicants. And this means that when considering an application for a humanitarian visa, the processing officer is no longer required to consider the potential costs to Australian health and community care services as part of their review. So this has been an enormously beneficial for refugee families who have a member with a disability, who previously would not have gained entry to Australia. An estimated, and these figures are a little contested, I think, but an estimated 1.4% of the 17,555 humanitarian visa recipients in 2015-16 received a health waiver. And by our calculations, that equates to approximately 600 people from Syria and Iraq alone. New South Wales and Victoria, of course, received the largest proportion of new refugee arrivals. So refugees with disabilities are a marginalised and disadvantaged group at all stages in their journey. In their country of origin, many belong to oppressed minority groups with consequential barriers to accessing services and reduced capacity for community support. Problems with service access are exacerbated when the health and support services are compromised by war. So in many cases, an accurate diagnosis of disability is never made, and lack of that proper assessment and diagnosis would prevent access to appropriate early intervention and support services, supposing they were even available in the country. And they may also affect the way the person with disabilities themselves is perceived by their family and their community. So a disability may also impact on access to education and employment opportunities due to stigma and/or limited capacity to accommodate the person's needs in those settings. Long-term experience of exclusion and marginalisation means that people often have poor health and disability literacy, so they don't necessarily understand the services and processes that might be there. Humanitarian visa recipients are eligible to access Australian supports and services, including, of course, disability services, health services, education, and welfare entitlements. But our research and others has identified that there are considerable barriers for people trying to access these supports and services, including, as you will be aware of, limited English language skills, lack of information in people's languages, cultural differences, especially in relation to how disability is viewed and supported, the high cost of many services, and services not meeting people's needs, often due to those cultural differences. So while there are clear implications of the changes to the humanitarian visa health waiver for Australian services, a review by Catherine Soldatic and colleagues published in 2015 reported that refugees with disabilities were almost never mentioned in Australian resettlement literature or disability research. So the number of refugees with a disability who have resettled in Australia to date is unknown because this level of data is not routinely collected. We also know little about people's circumstances living in Australia or about how their refugee journey to Australia impacts on their lives once they are here. So a stream of research conducted by myself and colleagues at Deakin University and UNSW Sydney and Black Dog Institute in partnership with STARTS and other partner organisations over the past 6 years has sought to find out more about the experiences of refugees with disability and their family members, in particular from Syrian and Iraqi refugee backgrounds, as the largest group at that stage. So in the first study we conducted, it was called Disability in Southwest Sydney, Experiences of the Iraqi and Syrian Refugee Communities. And this was a collaborative research project funded by Southwest Sydney Research and involving academics and service providers with expertise in refugee, disability and mental health. Mariano Colo from STARTS was the lead investigator on the project, and it was just a small scale project, really exploratory, dipping our toe in the water, if you like, to see what we could find. And it was just funded for 12 months. We designed the study over 2 phases. In phase 1, we were ambitiously aiming to collect or to compile some occasions of service data to try and estimate the number of people with disability accessing settlement and refugee health services in Southwest Sydney. But we just could not complete that part of the project. We found that the services just weren't routinely collecting data about disability. So it just wasn't worth really looking at what was collected because it was just not suitable for purpose. So the first phase also included some interviews with refugee and health service practitioners, which we thankfully were able to complete. And then phase 2 involved interviews in Arabic with family members of people with disability in from Iraqi and Syrian refugee backgrounds, and also interviews with Syrian and Iraqi community leaders in Southwest Sydney. 24 people were interviewed over those 2 phases, including 9 family members, 7 of whom were Iraqi and 2 Syrian. 5 were mothers, 3 fathers, and 1 adult sibling. And 3 family members had more than 1 person with disability. So those 9 family members were actually talking about 11 people with disability. We interviewed 7 service providers, and they were practitioners who were employed in 4 refugee and health agencies, employed as social workers, nurses, counsellors, early childhood workers, occupational therapists, and paediatricians. And then the third group were the community leaders. We interviewed 8 community leaders from a mix of Syrian and Iraqi organisations, and they were providing a range of services to people, including training opportunities, all within that Southwest Sydney area. So due to time constraints, I'm just going to give you the highlights of the findings from this study. We've published a number of papers on this work, and which you can access, and I've got some reference list there, which you can have a look at when you view the slides. From the perspective of family members, there were three main themes that we found. One was around the perceptions of disability, where participants told us that in their experience in Iraq and Syria, people with disability are wholly defined by their impairment, rather than being viewed as individuals with a range of abilities, interests, and skills. There was a common view that people with intellectual and psychosocial mental health disability experience more stigma than those with a physical impairment, especially when the physical impairment may have been acquired due to conflict and war. Participants noted that people with disability were commonly viewed as objects of pity and largely kept out of the public eye. And when we were analysing the data, we discussed the fact that these findings, these descriptions, were really not so different from the way people with disability were historically viewed and treated in Australia and many other countries around the world. The second theme that we defined as who is responsible for the disability. Here, participants told us that mothers are often blamed and feel that they bear the responsibility for their son or daughter's disability. This view was often experienced from the husband's family, and led to concerns about the impact of the person's disability on the family's other children and extended family members, for example, in relation to their marriage prospects. And disability was also viewed by some as a test from God to both the person with disability themselves and family members. The third family member theme revolved around comparisons between Iraqi and Syrian and Australian views, attitudes, and approaches to disability. Family reported that in Australia, their family member with disability was treated with dignity and provided with opportunities and support to live their life. Their view was that attitudes and actions towards disability were very different in Australia than in their countries of origin. And we reflected on why some of that may be, which I'll talk to a little bit later. I just wanted to share with you a quote from one of the mothers that we spoke to. She said, "These are the views of the Iraqi community. Even their father felt like the Iraqi community views him as weak because he has children with various disabilities. Slowly, we isolated ourselves from the Iraqi community as much as possible. Their dad would often leave and go where he needs to go by himself, and I would stay with the children at home. He wouldn't want to stay with us. I had to bear the full responsibility for caring for the children. I have to bear it, whether it's from their father or from the Iraqi community. This is why we had to come to Australia." The service provider themes included an overview of the organisation's response to disability, which was discussed under a number of sub-themes, where people spoke about having access to pre-arrival information so that they were able to triage people's needs upon arrival. There was also talk about the sort of arrival response that services had, sometimes welcoming people at the airport, but also providing orientation and feeling a need to educate the broader community as people came in to settle. There was also a discussion around the establishment of disability-specific support groups within organisations and the establishment of disability-specific supports and services. So where there might be a team of practitioners, including bicultural workers, and that this was really put in place because of response to waiting lists, that people just took a long time to get access to other sorts of services. Overcoming language barriers and resettlement issues and gaps in service provision were also discussed under that response. The second theme then was from the practitioners or the service providers, was around cultural understanding of disability, and included things like gender issues, the differences between the roles of mothers and fathers or brothers and sisters, attitudes to disability, which was raised by the family members around things like shame, guilt, stigma, unrealistic expectations of a cure. Family and community, again, around trust and stigma and language and cultural mores. Interestingly, within this theme, there was a viewpoint around seeking the views of the person with disability, that often there was an indication that people with disability weren't necessarily listened to within the family context. And so that would raise some important concerns as well. The third theme then, probably not unsurprisingly, was around the experience of the National Disability Insurance Scheme. And there they talked about access to NDIS information, families not knowing where to start, what to ask for, language barriers and waiting times. They talked about eligibility to the NDIS, including access to and the cost of assessments to prove your eligibility. And they talked about the NDIS planning process, that organisations needed to do a lot of pre-planning work with people, getting assessments and reports ready, preparing families for the meetings, and then were also involved in implementing the plan, making sure that people got access to therapy and that they were able to access interpreters to do that. So pretty comprehensive. Just sharing with you again a few quotes from the practitioners. One person said, due to the increase of people with disabilities in the last 2 years, our service has set up a disability support team, 3 nurses and a social worker, and this is in recognition of the increased numbers and complexity of people with disability from refugee background. Another said, some service nurses are language proficient, or they work with qualified healthcare interpreters. The bilingual community educators do community-based education and health orientation when refugees arrive. And another, we get people in the intense resettlement stage or phase, so there is only so much they can take on board. We think about immediate needs in the first 12 months and focus on what the family can handle at any one time. So in terms of what we heard from community leaders in this study, there were 5 themes here. One was around understanding of disability, which was viewed as varied across the Syrian and Iraqi communities, with different attitudes towards disability, which was genetic rather than acquired, and intellectual rather than physical. And you can see that resonates with what we heard from families. The prevalence of disability in the community related to the community leaders reporting greater numbers of people with disability and family members accessing their services over time. Leaders really highlighted the important role of family in supporting people with disability. They spoke about community inclusion and exclusion, about either increasing or decreasing participation of people with disability and family members in community events and activities. And lastly, they spoke about the need for information, resources and training as a way of increasing access to services and supports for those people. So as you can see, there are commonalities across what we heard from the 3 participant groups, particularly around perceptions and responses to disability. And there are a number of implications that we drew from this study. Firstly, family and community beliefs and practices are underpinned by people's social, political and economic living conditions, whether that's in their country of origin or once they resettle in Australia. These beliefs and practices are important and dynamic factors in understanding disability across cultures. Cultural safety and appropriateness are important for good outcomes for persons with disability from Iraqi and Syrian refugee backgrounds. There are important implications for understanding the ways in which organisations support the complex physical and mental health and social needs of people. Inclusion of people with disability to attend community-based programs, trips, events and ceremonies is really important. And supports that are provided by community groups complement but don't replace or duplicate government and non-government services. So some really important findings from that very small scale exploratory study, which was really beneficial. So leading on from that work then, the second study that I'd like to present to you tonight was called Co-Designing Resources with People with Disability from Syrian and Iraqi refugee backgrounds. The impetus for this study was based on what we heard from people in study one about the lack of information in Arabic language. For the second study, we retained many of our partners from study one, and we added a Victorian perspective as I moved to Deakin University in Melbourne in April 2019. This study was funded by a grant from the National Disability Research Partnership, which is hosted by Melbourne University and funded by the Department of Social Services. And again, tight time frame, funding was provided for 10 months and focused on a co-design approach. The research involved a 4-step process. Step one was a desk-based review of the literature, which was really about identifying from the literature what were the gaps and barriers for people accessing services. From that review, we created a 1-page plain language summary of the key points, which was translated into Arabic and shared with workshop attendees prior to their engagement. So that provided a bridge between the evidence base and the lived experience. Step two involved Arabic language workshops, which due to COVID were mainly online, with 38 people with disability and family members from Syrian and Iraqi refugee backgrounds. And this was to really put flesh on the bones of what we had heard in the lit review, was really to identify information gaps and barriers and what people felt they needed to access disability and refugee sector services and support. And it ensured that the information that was then taken into the co-design process, which is the stage 3, was up to date and relevant to our geographic locations. The transcribed and translated recordings of the workshop discussions were analysed using a content analysis approach to identify the key areas for the co-design groups to develop resources for. Step 3 then involved formation of an online bilingual co-design group that involved 16 people, some of who were workshop participants from stage 2, some were service providers, and some were part of our academic team. And our role as the co-design group was to plan and oversee the resource content and development. And we then worked with professional video production companies and Deakin University graphic design students to create the final versions. Step 4 involved the service partners and co-design participants developing a knowledge exchange plan to inform the dissemination of the resources. Underpinning this plan was the notion of using trusted places and spaces where people with disability, family members and service providers would typically go to find information. And this step, of course, also involved traditional academic knowledge exchange through publications and conference presentations. Not sure how I'm going for time here, but I'll try and get through this next little final bit fairly quickly. So I just wanted to provide a little bit of information about what our approach, our participatory action research and co-design approach entailed. So action research is really about building a collaborative space for the intersections between people with lived experience, practitioners and academics. And in that space, co-researchers are sort of active agents in co-producing new knowledge. And it typically involves an iterative cyclical process of planning, observation and reflection with the goal of creating innovative solutions. So there are 4 key principles to co-design: sharing power, prioritising relationships, using participatory means, and building capacity of everyone, recognising that everyone has something to teach as well as something to learn. Although relatively small scale, this project included a number of complexities, highlighting practicalities and pitfalls, as well as potential for future work. In terms of practicalities, there were both challenges and solutions. And a major challenge for us was the language barrier. So none of the academic researchers speak Arabic, but to really help overcome this, we employed we adopted a bilingual approach right from the beginning, and employed Mahmoud Murad, who's a man with disability from a Syrian refugee background, to work as our project manager. We'd worked with him before. We knew how passionate he was about this. We also worked with our partner organisations to ensure that the co-design group included workers who were bilingual in Arabic and English. And both these strategies really facilitated a full and active engagement of service users throughout the project. Another not unrelated challenge was our ability to connect with Syrian and Iraqi communities to recruit participants to take part in the workshops. And we really leveraged the partners, contacts, as well as those at Mahmoud. And we could have recruited far more than the 38 people who took part. We were limited by finance and time. And these connections also assisted with establishing trust and supporting people to be part of the project, overcoming some of the concerns that people may have had about speaking about their experiences and perhaps being unwilling to openly criticise services in their new country. Of course, COVID-19 caused us problems. We conducted one workshop in person in Melbourne, and then everything else was online. But really, the converting to online meant that we were actually able to include more people, and people from outside metropolitan Melbourne and Sydney. So in a way, it was a bonus for us. We had to complete the work in 10 months, as I said, although the actual production of the resources went on a bit longer than that. But so we had a condensed co-design process, which was a big ask for people. We met weekly for 2 hours over the course of a month. But the benefit was that we maintained momentum between the group sessions. So despite, or perhaps because of these pitfalls, we recognised the potential of the work, what we'd do again, and why we'd do it. And I think in the interest of time, I won't go through this in detail. I've covered some of these points already around language, around the multiple perspectives, around the bilingual co-design group facilitation, and just saying that part of what we produced was very visual outputs and resources, which are really accessible and engaging for people. The co-design groups decided to focus on producing resources on 3 main topics identified as important from the workshops: oral health, the National Disability Insurance Scheme, and support for family members. The outcomes of the project included an oral health postcard describing in Arabic why oral health is important for people with disability and where to find supports and services. 6 short Arabic language videos providing information about the NDIS, what it is, what a plan is, what to do once you get one, your rights as a participant, asking for a review of a NDIS decision, and making a complaint about an NDIS service provider. There is some information in Arabic on the NDIS website, but participants told us that this was limited and didn't address the issues of making a complaint. And the final video is a short Arabic language video on families with disability. I was hoping to show you one of these tonight, but we couldn't get the technology to work quite seamlessly. So the links are there and you'll be able to access those. And I think STARTS probably also has them on there with their website. So just to finish up then, This body of research, which we've conducted in partnership with Refugee and Disability Services and people with disability and family members from Syrian and Iraqi refugee backgrounds over the past 6 years, is some of the first in the world to explore the challenges and benefits experienced by this group in their settlement in Australia. And we're continuing to seek funding opportunities to further this work. We've got really strong partnerships and all of us are really committed to further work in the area. And as I mentioned, I've got some references there which you will be able to access from the PowerPoint. Now I'm just trying to get my mouse to work so I can stop sharing. Thank you.